mimetic agents and parasympathetic agents or myotics. It has been used for the treatment of glaucoma for more than 100 years, and they are divided into direct acting cholinergic agent agonist and indirect acting anticholinesterase agents. And the direct acting agent pilocarpine continues to be used in certain circumstances. It's not commonly prescribed for long-term use. In patients with pigmentary glaucoma, pilocarpine is effective, blending the IUP spikes that can occur with the physical activities such as running. The drug is also useful in the management of elevated IOP in aphakic eyes and patients whose drainage angles are persistently occludable despite of laser iridotomy. It has been associated with the poor patient adherence to the regimen because it adverse effects and the dosing. It is 3 to 4 times per day. A lower concentration and dosing frequencies may be acceptable for management of angles with persistent iridotrabecular contact with a patent peripheral iridotomy. Here we can see pilocarpine, lower doses from lower doses to higher doses are there, and 2 to 4 times daily dosing, and mechanism of action increased trabecular outflow and IOP reduction 15 to 25, like both are same. Indirect acting and pilocarpine all are same. And next, indirect acting agents are not using because of their ocular and systemic adverse effect. They can very effective and well tolerated in aphakic eyes with glaucoma, but not using like that. And mechanism of action, longitudinal ciliary muscle fibers that insert into the scleral spur, trabecular meshwork, and inner canal of slum inner wall of Schlum's canal. These will contract and improving outflow facility by causing an unfolding of the trabecular meshwork and widening of the Schlum's canal. Direct acting agents affect the motor end plates in the same way as acetylcholine, like they are acetylcholine anticholinesterase, which is transmitted at postganglionic parasympathetic junctions as well as in other autonomic, somatic, and central synapses. And pilocarpine can reduce IOP 15 to 50% up to 25%. And indirect acting agent inhibit the enzyme acetylcholinesterase. And they are prolonging the action of acetylcholine junction. Adverse effects. Myotic agents have been associated with the numerous ocular adverse effects. Induced myopia resulting from ciliary muscle contraction is an adverse effect for all, and brow ache may accompany the ciliary spasm. The meiosis interferes with vision in dim light condition. In patient with the significant lens opacities and vision is adversely affected in all most of the light conditions, and because of myotic agents have been associated with the retinal detachment, a peripheral retinal evaluation is suggested before the initiation therapy. And indirect acting agents may be cataractogenic. Indirect acting agent may induce formation of iris pigment epithelial cyst and can cause epiphora by both direct lacrimal stimulation and punctal stenosis. They may cause ocular surface changes that result in drug-induced ocular pseudopemphigoid. Other potential ocular adverse effects include increased bleeding during surgery and increased inflammation and severe fibrinous iridocyclitis post-operatively. Because myotics can break down the blood-brain barrier, blood-aqueous barrier, they should be avoided. If possible, patient with the uveitic glaucoma. Use of myotics occasionally induce paradoxical angle closure in eyes, particularly in eyes with the phacomorphic narrow angles. Contraction of ciliary muscles lead to forward movement of the lens iris interface and increased anteroposterior lens diameter, which cause or exacerbate pupillary block in eyes with a large lens. Systemic adverse
Go to the
effects
previous slide. Previous third slide, 3 slides. Go back. Go back. Go back. Yeah. That is the thing. Next slide. Next. back to back slide. Go back to the slide. Mechanism of action. See, pilocarpine was used in both open angle and closed angle glaucomas. Okay. So this is the mechanism of action which is causing the angle to open, right?
Sir.
So it is an angle closure. The mechanism of action is in angle closure glaucoma. But the mechanism of action of pilocarpine open angle glaucoma is also there. So it just increases the conventional outflow, trabecular mesh outflow. Okay, that was the only drug previously when the treatment was started for glaucoma. It has both the actions. Opens the angle and also it functionally clears the block of open angle.
Yes, sir.
I just read that also. Mechanism of action is there for another mechanism also there for pilocarpine. And when side effects are there, have you mentioned about drug-induced myopia?
Sir. Myopia, no, sir. Myopia, not drug-induced myopia, but
I don't think so.
like induced myopia resulting
Yes.
from ciliary muscle condition, adverse to all the cholinergic cases.
Okay. It is there. Induced myopia is there. Yeah.
The one sentence only, sir.
Okay. So these irises and all by direct acting also, pilocarpine also. This is all retinal detachment, irises, paradoxical, people like talk, everything. Okay.
A systemic adverse effect, mainly with indirect acting medication, including diarrhea, abdominal cramps, salivation increase, bronchospasm, and even enuresis. And depolarizing method relax such as acetylcholine cannot be used up to 6 weeks after stopping indirect acting agents. Here the table, here we can see like exacerbation of cataract effect is more effective in lighter irids, and the pilocarpine can cause, and the washout period is 48 hours. And anticholesterase is not using, but mechanism of action and IOP reduction all are same, and but ocular side effects like intense miosis, iron pigment system, myopia, cataract, RD, angle closure, punctual stenosis, and pseudopemphiod and epiphora are there, and systemic adverse effects same as pilocarpine, and increased. This can cause increased inflammation with ocular surgery. And anesthesia risk will be there, prolonged recovery it can lead to, and it is useful in eyelid lash lice cataract surgery post-operatively.
Can you enumerate the washout periods for all the groups as of now we discussed?
Sir.
Just enumerate.
Washout period.
Washout period for different groups of drugs.
Sir, washout period for
No, don't go back to slides. It will be difficult. So especially, I just want to highlight the pilocarpine. It's only 2 days, which will stay in the eye. So rest all the things will be around
1 month.
At least around 4 weeks. So, for example, say if you want to treat a steroid responder, so you will stop the drug or you will taper the steroid in a frequent manner and give the AGM, right?
Yes.
So when you know that steroid response is vanished out. So you will give an anti-glaucoma medication along with tapering of that steroid, right? And you will have a reduction of IOP, right?
Yes, sir.
And at least for 2 weeks you will use that, and after 2 weeks you have to taper the AGM. If it is a fixed combination, you just come to the monotherapy, or it is in monotherapy, you just stop the AGM, right? And you will see them after 1 month. Why? Because that is washout period. That is the washout period for AGM. Okay. So after 1 month, you will reassess the IOP. If it is raised, then you have to start again. Right. Steroid response is going to be permanent in that patient.
Yes.
If it is not increased, then you will stop the treatment.
Yes.
So do you get my point? Why washout period is important?
Yes, sir.
After stopping the AGM, you have to wait at least for 1 month.
Yes, sir.
To reassess what is the normal IOP without any AGM. So you just stop the AGM and call them after 1 week and measure the IOP. It is not correct. Okay.
శివకృష్ణ గారు
Madam.
అంగారెడ్డి కూడా వన్ steroid responder case which you have seen. He's a young patient at 15 years old. Only left eye he is having cupping. You started with AGM in left eye, and now the pressures are under control, but the changes are there. We have to continue or
we have to continue, ma'am. It might not be a steroid responder. It might be a steroid induced glaucoma. Which steroid he is using and why he is using?
I don't know. He's an asthma patient.
Okay.
Only left eye you have prescribed. I asked him to continue.
Yeah, he has to continue, ma'am, because whenever the ONH changes comes, we'll call it as glaucoma only. So it's steroid induced glaucoma maybe. So
only left eye, not right eye. You prescribe for only. I asked him to continue and come after 1 month.
Yes. And after
we should not stop.
We should not stop, and pulmonologist reference is also needed. To have an alternate drug.
Okay, I will ask him to go pulmonologist.
Yes.
Okay, thank you.
Next is rock kinase inhibitors. And the rock family of G proteins are activated by various cytokines and regulate various aspects of cell structure, and including cell stiffness, cell morphology, cell adhesion, apoptosis, and smooth muscle contraction. The factors of this G protein are rock kinase, rock kinase 1 and rock 2, and activated rock kinase phosphorylates various downstream proteins, including myosin light chain phosphatase. The net result of this activity is increased phosphorylation and activation of myosin light chain. And phosphorylated MLC interact with the actin and it's altering the physical characteristics of cytoskeleton and thereby leading to increased cell stiffness and smooth muscle contraction. So the rock kinase inhibitors lower IOP primarily by relaxing the cytoskeleton of outflow cells in the trabecular meshwork and Schlemm's canal, increase. Hello, sir.
Yeah, what happened?
I don't know, sir.
Share the slide again.
Okay, sir. Sir, is visible, sir?
Yeah, it's very visible.
Okay, sir. Okay, and that's the rock kinase inhibitors lower IOP primarily by relaxing cytoskeleton of outflow cells in the trabecular meshwork and Schlemm's canal, increasing conventional outflow facility. And available agents and dosing frequency for Ripasudil, it's a mixed rock kinase inhibitor 1 and rock kinase inhibitor, that's inhibitor 2, and was the first rock kinase inhibitor available for clinical use to lower IOP, and it's used in Japan and approved in Japan, and another one is Netarsudil. And the only rock kinase inhibitor approved for the use in US, and which was approved by the FDA in 2017, Like ripasudil, netasudil is a mixed ROC1 and ROC2 inhibitor, and is also a norepinephrine transporter inhibitor also. The norepinephrine transporter inhibitor activity is thought to result in reduction of episcleral venous pressure and may also decrease aqueous humor secretion. And this is not been this mechanism is not demonstrated in humans. In clinical trials, its IOP lowering efficacy was similar to or slightly lower than that of timolol. Some clinical trials were focused on eyes with fairly low baseline IOP because it was thought the drug might be particularly effective in such eyes. In 2 clinical trials in which the mean baseline diurnal IOP was approximately 22 mmHg and the IOP reduction achieved with once daily netasudil 0.02% was approximately 20%. The drug lowers IOP by an additional 1.3 to 2.5 mmHg when combined with the latanoprost. Mean IOP lowering with the netasudil used as a monotherapy or in combination with the latanoprost in clinical trials appears to be modest. Some patients respond very well, experiencing substantial IOP lowering. Netasudil is used once daily. The hyperemia that commonly occurs with this class of agents is most intense during the first few hours after instillation. And so nighttime dosing is preferable. Adverse effects. The most common adverse event.
So there are 2 studies, Shilpa.
Sir.
You have to read about rocket trials. That is for ROC kinase inhibitors.
Rocket.
That is the only large study for rocket that is called rocket trials. Okay.
Sure.
And you have mentioned about netasudil concentration, that is point. Are you listening?
Yes, sir.
Hello.
Okay. Sir, listening.
Netasudil is 0.02%. Ripasudil is 0.4%.
It didn't mention.
So in the at the end of this medical management, you have to. I will ask you the concentrations. Okay. You just study with that.
Sure.
Yeah. Continue. Adverse effects you have to read.
Adverse effects. Ripasudil. So mixed and it's first no sir. Most common adverse effect with ROC kinase inhibitors is conjunctival hyperemia. It occurs in more than 50 to 60% of patients and is thought to be a result of conjunctival vascular smooth muscle relaxation. And with netasudil, subconjunctival hemorrhage can occur in 50 to 20% patients. Eye pruritus, punctate keratitis, increased lacrimation, blepharitis, decreased visual acuity. Where reported decreased visual acuity reported in 5 to 10% of patients. Cornea verticillata was observed in 15 to 25% of patients after 1 year of use. This cornea verticillata is similar to that observed after long time use of amiodarone. It does not seem to adversely affect visual function.
Do you know what is cornea verticillata?
This, sir, picture this kind of
pigment deposition. It's a pigment deposition over the cornea. This is over the epithelium.
Sure.
Corneal epithelium.
And
it's like a vertical stripe.
Sir, it's like some
striae.
Striae. Sure.
Pigment deposition on the epithelium, corneal epithelium. That is what is. Okay.
Sure.
Corneal deposits is a question. Sure. At various levels of corneal epithelium, stromal deposits, and endothelial deposits.
Sure.
Do you know KF ring?
Yes, sir.
KF ring is seen in which disease?
Sir, KF ring is seen in Wilson disease, sir.
Wilson disease. Copper deposition in the Descemet's membrane.
Descemet's membrane.
So you have to read corneal deposits. That will be a question for you. Yeah, continue.
And this cornea verticillata resolves after 1 year after discontinuation of the drug. It's thought to occur as a result of lysosomal accumulation of phospholipid in corneal epithelial cells. And combined medications. Next.
And you have one more thing is like honeycombing of the epithelium. Epitheliotoxic actually, ripasudil.
Sir.
Ripasudil is an epitheliotoxic.
Sir.
So you will get a honeycomb appearance of epithelium.
Sir.
Clinically also you will get that honeycomb pattern. So after discontinuing the drug, it will go.
Epithelium. By ripasudil, sir.
Ripasudil.
Okay, sir. Sir, ripasudil, the dosage is 0.04. Yes, sir.
No, 0.4. It's high concentration.
Okay, sir.
Netarcidil is 0.02.
Okay, sir. Next, fixed dosing. Medications combined in a single bottle have the potential benefits of improved convenience and patient adherence. Fixed combination consisting of timolol and another agent like carbonic anhydrase inhibitors or an alpha-2-adrenergic agonist, most commonly brimonidine, and CAA may be dorzolamide or brinzolamide, and prostaglandin analogs like latanoprost, travoprost, bimatoprost are available in many countries. In addition, fixed combinations of brimonidine and brinzolamide and latanoprost and netasudil are also available. The efficacy of fixed
Can you name any commercially available these combinations? Can you name some? No, go to the next slide.
The efficacy
See, that is the thing. No.
Sir.
Go back to the scene. Go back to the previous slide.
Okay, sir. This slide,
No, that slide.
This slide. Okay, sir.
This slide. So when you combine with dorzolamide and timolol, do you know any brand name for that?
Apatim, sir.
Huh?
Apatim? No.
I am asking about combination. What apatim contains?
Timolol, sir.
Only timolol. I am asking about dorzolamide with timolol.
Dorzolamide.
Sonika?
I know Drojit करके something I see one drug sir Drojit takes no sir Drojit takes something is see in cards and remembering that
Dorzolamide with timolol having a Dorzox T or Mysopt.
Dorzox T I see sir.
Or Mysopt. I'm just you have to remember. You have to see and remember. What is brinzolamide with timolol? It is available in our pharmacy also. Brinzolamide with timolol. Azarga is there.
Sir.
Azarga. Go to our pharmacy and see.
Sir.
What about brimonidine and timolol? Commonly used combinations.
Brimalox.
Have you read? Have you listened that Combigan?
Yes, Combigan.
Combigan is nothing but brimonidine timolol. You have to see all these things.
Sir.
Latoprost with timolol. Travoprost with timolol. Latanoprost is Zalocom. Alcon. Zalocom. Zalatan is latanoprost and Zalocom is combination with timolol.
Sir.
Avatan is travoprost and Travacom is timolol combination. Travacom. With bimatoprost. Have you heard about Ganfort?
Yes, sir.
Ganfort.
Yes, sir.
Ganfort is bimatoprost with
You
timolol.
don't know about the commercial names, I think.
They should know, man.
Yes.
Already they were seeing in OPDs, no?
Go to pharmacy and find out which one is.
Yes, ma'am.
Brimonidine and brinzolamide, it is Simbrinza. Simbrinza.
Yes, sir.
Okay. Yeah, you are seeing already, whatever the cases I have seen, you are seeing in reviews, no?
Sir.
You have to search what is this drug.
Sir.
Okay. You are already 6 months now?
6 months, sir.
Okay. Okay. Yeah. Continue.
Efficacy of fixed combination formulations is similar to that of components instilled separately. In case of fixed combination agent that include timolol and are administered twice daily, the total amount of beta blocker may actually be more than necessary because nearly full effect of beta blocker can be achieved with once daily dosing. The ocular adverse effects are the same as both drugs given individually. In general, except in the setting of acutely elevated or dangerously high IOP, the clinician should reach component of the fixed combination is effective in further lowering of the IOP by adding the individual components sequentially. Here, fixed combination at timolol brinzolamide at two times daily and timolol dorzolamide, timolol latanoprost, here timolol travoprost, timolol ibimatoprost, timolol brimodidine, brinzolamide and brimodidine, brinzolamide and latanoprost and netarsudil combination. In this, netarsudil is 0.02 and latanoprost 0.05 and once only night time. Here, for most of the things, washout period is 1 month, almost all. This case also 1 month because sir, this case of the Latin approach letter combination is also 1 month, sir, because sir.
Actually, it is not commercially available in India. It's only 1 month and it's 9 time only, but we don't have any clinical exposure to that because it is not available as of now in India. We didn't use that.
Okay, sir. Next, hyperosmotic agents. Hyperosmotic agents are used to control acute episodes of severely elevated IOP. Common are oral glycerol, intravenous mannitol. When given systemically, hyperosmotic agents increase blood osmolarity, creating an osmotic gradient between the blood and the vitreous humor that draws water from the vitreous cavity and reduce IOP. Because of the increased gradient, the higher the dose of administered and more rapid the administration. Following greater the subsequent IOP reduction will be. A substance distributed only in extracellular water, example mannitol, is more effective than a drug distributed in total water. That is, for example, urea. The osmotic agent enters the eye more rapidly when the blood-aqueous barrier is disrupted than when it is intact, reducing the effectiveness of the drug and its duration of action. Hyperosmotic agents are rarely administered for longer than a few hours because their effects are transient, a result of the rapid re-equilibration of osmotic gradient. They become less effective over time. Rebound elevation of IOP may occur if the agent penetrates the eye and reverse the osmotic gradient. Adverse effects of these headache, confusion, backache, acute congestive heart failure, myocardial infarction. The rapid increase in extracellular volume and cardiac preload caused by these agents can precipitate or aggravate congestive heart failure. And IV administration is more likely to cause problem than oral administration. And subdural and subarachnoid hemorrhages also reported after treatment with hyperosmotic. Glycerol can hyperglycemia precipitate or even ketoacidosis in patients with diabetes because it is metabolized into glucose and ketone bodies. And hyperosmotic agents are contraindicated in patients with renal failure. This mannitol parenteral concentration is 20%, glycerol is oral 50%, and its dosing is according to the body weight 0.5 to 2%, 2 gram per kilogram. In case of mannitol and glycerol, 1 to 1.5 gram per kilogram. And ocular side effects, rebound IOP, increased aqueous flare. And systemic side effects, we already discussed the cardiac and CNS related, and it's used in mannitol, is used in acute increase in IOP, that cases, and cholesterol can precipitate diabetic ketoacidosis, and mannitol is contraindication in renal patients and cardiac patients. Then general approach to medical treatment. Long-term therapy. The ophthalmologist should tailor ocular hypertensive therapy to the individual needs of the patient, including establishing target IOP. And IOP is the only of the several factors to monitor, and we have to monitor optic nerve, retinal nerve fiber layer, and visual field status. Treatment is usually initiated with a single topical medication unless the baseline IOP is extremely high. In that case, 2 or more medication can be indicated. Prostaglandin analogs and beta blockers are the choices as first-line therapy for open-angle glaucoma, and prostaglandin analogs are the most commonly used first-line agent because of the superior efficacy, once daily dosing and safety profiles. Local adverse effects of beta blockers are minimal. These drugs have a greater potential for systemic adverse effects. They lack nocturnal IOP lowering efficacy. If prostaglandin analogs and beta blockers are contraindicated or ineffective, we can use Rho kinase inhibitors, brimonidine, a topical carbonic anhydrase. If one agent is not adequate to reduce IOP to the desired range, the initial agent may be discontinued and another tried, or another can be added. Laser trabeculoplasty, if appropriate, can be considered at any point during stepwise process of intensifying treatment or as the initial treatment. For patients on prostaglandin analog, if a second agent is required, it's reasonable to add a beta blocker, alpha-2 adrenergic agonist, topical carbonic anhydrase inhibitors, Rho kinase. All have a similar addictive mean diurnal IOP lowering efficacies, but carbonic anhydrase may have better nocturnal efficacy. The decision as to which of these would select is based on its adverse profile, dosing frequency, contraindications, and preference of the patient. And patient may not be able to tolerate multiple topical agents because of their preservative agency, preservative toxicity. Benzalkylinium chloride, the agent most commonly used as a preservative, is present in most of the currently available topical ophthalmic eye drops. If reaction is suspected, an ocular hypotensive agent with an alternative preservative or preservative-free formulation can be used. This is a preservative-free and alternatively preserved ocular hypotensive agents. BAK is benzalkylinium chloride, timolol containing preservatives and related to BAK, and others are, these are different formulations with different preservatives. For rehabilitation of ocular surface, stop all topical medications if the glaucomatous damage level permits, and have a patient use preservative-free artificial tears frequently. During this period, the temporary use of a oral carbonic anhydrase may helpful to lower IOP if needed clinically. Therapy for acute intraocular pressure elevation. Goal of the medical treatment of acute IOP elevation are to prevent further damage to optic nerve, clear corneal edema if present, reduce intraocular inflammation. And hyperosmotic agents and systemic carbonic anhydrase may required in order to lower IOP in eyes with severe IOP elevation, and preparation for the definitive treatment. When IOP is severely elevated, ischemia of the pupillary constrictor muscle can interfere with the myotic action of pilocarpine and other parasymptomimetic agents. Therefore, in patient with acute primary angle closure, lowering the IOP is also lowers pupillary constriction before an iridectomy preferred. Severely elevated IOP may cause collapse of the Schlemm's canal and closure of the collector channel. Reduction of IOP may help you restore conventional outflow. Next, administration of ocular medications. Patient should be shown how to instill eye drops properly and should be given instruction on nasolacrimal occlusion, which can be used to reduce the systemic absorption of topical medication, and also we can prolong the ocular contact time. Direct the patient to close their eyes for 1 to 3 minutes after instillation of the eye drop will also promote corneal penetration and reduce systemic absorption of the drug. and by reducing the flow of these to the nasolacrimal drainage system. Eye drops that need to be administered at the same time should be separated by 5 minutes to prevent washout of the first drug by the second. This is two method of eye drop instillation. Method 1, here the patient is standing position, and method 2, patient is laying down position. First method 1, here washing the hand and pull down lower eyelid to make a pocket, and looking at the mirror, squeeze the drop into eyelid pocket, close eyes for 1 to 2 minutes. And this method, like first we have to wash hand, lay down, and use the finger on the hand holding the bottle to find the nose and stabilize your hand. And next, close the eyes and squeeze a drop into inner corner of the eye, and blink until you feel the drop enter your eye. Then close eye for 1 to 2 minutes. Then use glaucoma medication during pregnancy or breastfeeding mothers. And IOP decreases during pregnancy, both in healthy subject and patients with glaucoma. And but the patient need continuous therapy throughout the pregnancy. Topical ocular hypertension medication is systemically absorbed. They subsequently close placenta and other enter fetal circulation and can be secreted into breast milk. With all topical ocular hypertensive medications, pregnant and breastfeeding patients should perform nasolacrimal occlusion during eye drop instillation. The lowest effective dose should be given in this patient. An antifibrotic agent should be avoided. Prostaglandin analogs, previously listed in pregnant category C, and PGF2 alpha analogs have been shown to be embryocidal in rodent studies, and when administered in high dose. Travoprost is teratogenic, and PGF2 alpha exert abortifacient activity by increasing uterine contractility and may induce labor at higher doses. It's unlikely that topically administered prostaglandin analog places the fetus at a significant risk during pregnancy. Next, beta blockers. It's listed in pregnancy category C, but it's used for systemic hypertension during pregnancy and can cause growth retardation and ischemia, bradycardia, lethargy. And this agent can be concentrated in breast milk and are relatively contraindicated in breastfeeding mothers because of their potential adverse effect on infants. Next is alpha-2 agonist, and previously category B, and brimonidine is preferred agent for use during pregnancy because category B is included drugs for which animal studies failed to demonstrate a risk to the fetus. So we are using brimonidine because brimonidine has been linked to apnea in infant. It should be discontinued in pregnant women prior to delivery to minimize the risk of this complication in newborn. Brimonidine should also be avoided in breastfeeding mothers also. Carbonic anhydrase inhibitors is category C and teratogenic in rodents, and are the case reports of forelimb deformities in infants whose mothers were on systemic carbonic anhydrase during pregnancy. So we have to avoid systemic carbonic anhydrase, and topical also avoid, particularly during the first trimester. Use of glaucoma medication in elderly. It's elderly patients have greater difficulty in instilling their medication than younger patients, and their adherence to treatment regimen may be affected, and they have greater susceptibility to systemic adverse effect of glaucoma medication, and incidence and severity of systemic adverse effects may be higher with the beta blockers and alpha-2 adrenergic agonists because they have pulmonary and cardiac. Then, for example, a significant proportion of symptomatic elderly patients suffer a significant but reversible reduction in pulmonary function with the use of beta blockers. Next, sustained release bimatoprost implant in 2020.
So, what will you advise for elderly patients who are having these systemic effects. So after instilling the eye drops, one method we can advise the patient so that we can
nasolacrimal duct.
That is punctal block.
Punctal block.
Okay.
And sir, we can give punctal block also, sir, in OPD.
Punctal block is like they have to press their medial canthus area to not to be drained by nasolacrimal duct. They have to press their own medial canthus in both eyes. Okay.
Okay, sir. In 2020, the US
punctal plug which are given.
Sir?
It's not a punctal plug. It's not a punctal plug which we are giving.
Okay, sir. Okay.
Given by the patient's own hand.
Sir.
How many slides are there?
Last slide, sir. This one.
Okay.
This some pictures. In 2020, the US FDA approved the intracameral sustained release biodegradable bimatoprost implant for one-time use. The bimatoprost sustained release implant is composed of 10 microgram bimatoprost in a polymer matrix that slowly degrades after implantation in the anterior chain. Points like target pressure is an estimate of intraocular pressure level below which the rate of disease progression is expected to be sufficiently low as to minimize the patient.
We already discussed, right, these things.
Yes, sir. Just 3 points.
Next slide.
This pharmacologist, the picture is from.
Next slide.
Complete.
Okay, these are all you know, right?
Yes.
Slide.
So completed, sir.
Okay, go back to the previous thing. Previous one. In between. Wait. So you have mentioned about principles of glaucoma therapy, right? Manual. So it should be supported by the evidence. Okay. We have landmark studies in glaucoma therapy. Landmark studies. Okay. So the questions arising are why and when we have to treat ocular hypertension. Okay. Which study gives the answer? Why and when we have to treat ocular hypertension? Which study gives the answer? It's OHTS, ocular hypertension study. Okay. That will give the risk factors and also the treatment when we have to treat the patient, right? Okay, and why? And one more that I'm highlighting about landmark studies. You have to go through, at least you should know. Because if you get a glaucoma long case in your practicals, then definitely they will ask about management of glaucoma, and definitely they will go for a clinical trials, landmark clinical trials. Okay, one thing is OHTS, and second thing is whether you have to treat or you just why you are you treating, and why not the observation. So that gives by early manifest glaucoma trial, EMGT. So you just would note down the things. And you just read a brief
glaucoma trials.
Yes.
EMGT.
EMGT, early manifest glaucoma trial, right? And why you have to treat normal tension glaucoma? So this answer is given by CNTGS. CNTGS. Okay, collaborative normal tension glaucoma study.
Okay, sir.
Then whether the primary modality of the treatment is surgical or medical. This is given by CIGTS.
CIGTS.
Collaborative initial treatment for glaucoma study. Okay.
Yes.
And one more study is AGIS, Advanced Glaucoma Intervention Study. So they have done trabeculoplasty with trabeculectomy. Which is first to be done?
Sir.
The answer given by that study. Okay. And the tube versus trap study, TVT. TVT.
Sir.
So until unless we have these evidences, we cannot treat patients, right? So you have mentioned about prostaglandins as a first line therapy. Why? And if the patient comes to you with the 16 pressures with the 0.8 coupling, then what is the drug you have to give? So the 16 pressures with the 0.8 coupling, it's a target IOP, right? Moderate glaucoma without any medication, he is having 16 pressures, right? So why you want to treat? That should be given by CNTGS, because if at all it is a normal tension glaucoma also, 20 to 30% reduction from the baseline IOP will alter the progression of visual field loss. So even if it is a normal tension glaucoma, the pressure reduction halts the progression of visual field loss. So that's why you are starting that drug.
Sure.
Even if it is a low IOP.
Sure.
Did you get my point?
Yes, sir.
So definitely when you get a glaucoma case, as a long case only you will get a glaucoma case. So in Viva, they will definitely ask about this. Not might be a theoretical question, but you have to be familiar about these studies.
Sir.
Why are you choosing means you have to mention this study.
Okay,
because
sir.
the study evidence is given like this, so we are
Yes,
following.
sir.
Did you get my point?
Yes, sir.
As a see, some question may arise if the patient is from rural background. You might be seeing the patient in camp.
Sure.
The patient is not affordable for the medication, and he came for a cataract surgery, and you diagnosed it as a glaucoma. Then what is your primary modality of treatment? You can happily go for a phacotrabeculectomy.
Okay,
It's
sir.
a combined surgery. And why you will do? That is given by CIGTS, Collaborative Initial Glaucoma Trial. So that study tells you that even if it is a medical or a surgical, it is the outcome is equal in both the cases, both the group of
Sir,
patients.
that study name, sir, once more, please.
CIGTS,
GTS.
Collaborative Initial Glaucoma Treatment for glaucoma.
Okay, which is initial treatment. Like,
Yes,
sir.
medical versus surgical.
Medical.
The outcome is almost equal in medical and surgical. But the thing is, the patient selection is important. So if you want to treat a educated patient, you know the risks and complications of trabeculectomy, so you won't go directly for a trabeculectomy. You know that patient is adherent and compliant to your treatment, and you will be coming for regular frequent follow-ups. Then you need not to go for a direct trabeculectomy for that patient. It's the medical management we can start. But the patient is a rural background.
Sure.
And he cannot afford the medication, then it is the trabeculectomy, it will be a primary modality of treatment, right? So when you go for a principles of this thing, medical management, you just have to mention about these studies. Okay? Yeah, and you can just see in a landmark glaucoma trials, you will get some more studies also. I have told you around 6 to 7 studies I told you. Sonika, you also have to read all these things.
Sir, one study, sir, that you told traveloplasty or travelotomy, sir, which one is it doing like that? Which study, sir?
That is AGIS, Advanced Glaucoma Intervention Study. That is versus laser trabeculoplasty with trabeculectomy. It is not trabeculotomy. Laser trabeculoplasty with trabeculectomy, which has to be done first in advanced glaucomas. Okay. Then, again, the primary modality of treatment should be prostaglandins, but it is not a cost effective. Again, you have to see the individual basis of starting the medication.
Sure.
So if they are not properly explained, and they cannot understand the disease properly, if you have given 600 to 700 rupees drops,
Sure.
they don't come back to you and they won't buy also. Okay. You have to discuss with the patient that Is that okay? Can you use these drops or not? So if the patient is telling no, then you have to treat with a beta blocker. Right, it is also having 20 to 30%, but less effective compared to prostaglandin. It is also a better
And
drug.
sir, if the patient is having that congestive cardiac failure like that is there, then we should go with the prostaglandin, sir.
That's what I told you. Congestive cardiac failure is not a contraindication, especially rhythm conduction difficulty. If at all any contraindication is there, you should not.
If asthma like that, we can go for we should go for this prostaglandin, so the cost will be high now.
Yes, but we have to explain the patient that it should be beneficial to you. You have to sit with the patient, counsel the patient regarding the disease. Whatever we are discussing, everything we can discuss with the patient, right? What is the pathogenesis? Why it became like this? We can discuss with the patient. So fixed drug combinations, just tell me. We can finish that things. The first group of drug is beta blocker. What is the concentration of timolol?
0.2.
Don't go back to the slide. Sonika, you also tell.
Sir, timolol 0.2, like.
No.
It's 0.5. Okay.
0.5.
You have asked me around 0.25 to 0.5, no?
Yes, sir. 0. Both are same.
But it is 0.5, which is commercially available in India.
Okay, sir.
Okay. Timolol. Then what is the next group of drug?
Prostaglandin analog, sir.
Adrenergic agonist.
Adrenergic agonist.
Brimonidine, what is the concentration?
0.2, sir.
Yeah, and also it is available in 0.15% also. So different formulations to reduce the side effects also. 0.15 and 0.2 has having equal efficacy of IOP reduction. Okay. Then prostaglandin analogs. What are all the drugs available?
Latanoprost,
concentration?
0.02.
0.005. Very less concentration. 0.005.
Okay, sir.
What is travoprost concentration?
0.002.
0.004. Okay. And what is bimatoprost?
0.05.
There is only 0.01. Only 10. Bimatoprost is higher concentration. Okay. Bimatoprost is 0.01 or 0.03. Both are available. So, but equal efficacy. So we are using 0.01. Okay. Have you heard about Lumigan?
Yes, sir.
Lumigan is bimatoprost. Bimatoprost is having 0.01 and 0.03, both the concentrations. Okay. And what else? Other groups? Pilocarpine, what is the concentration?
0.5.
No 0 points in pilocarpine. No points in pilocarpine. It is 2%. Okay, it's a 2%. What about dorzolamide and brinzolamide? Dorzolamide is 2%. Brinzolamide is 1%. Okay. You have to be clearer with that.
Okay, sir.
Okay, you just go through all these things and you just write it down in one paper and stick onto the wall.
Okay, sir.
Not only glaucoma medications, you have to remember all the ophthalmic solutions which are percentage. Okay.
Yes, sir.
And you know rocaine, right? Ripacidil is 0.0. Netarsodil is 0.02. Okay. Any questions?
Yes, sir. No, sir. No questions, sir.
No questions.
Krishna garu.
Madam, చెప్పండి మేడం.
మా బాబాయ్ ఉన్నారు కదా, ఆయన ఊమిగానే వేసుకున్నారు. ఆయనకి ఏంటంటే హార్ట్ లో హోల్ ఉంది ఎప్పటి నుంచో. మార్నింగ్ మధ్య కొంచెం ఏమైందంటే పల్స్ రేట్ పెరిగిపోయింది, 200 వరకు వెళ్ళిపోయింది. వెళ్ళిపోయాక కంట్రోల్ అయింది. ఇప్పుడు హైదరాబాద్ లో ఉన్నారు ఆయన. ఊమిగానే వేసుకుంటున్నారు. వాళ్ళని అడిగితే వేసుకోవచ్చు అని చెప్పారు. నాకు ఎందుకో డౌట్ వచ్చింది, వేసుకోవచ్చా?
అవును మేడం, వేసుకోవచ్చు మేడం.
ఏమవదు కదా దానికి?
ఏమవదు.
ఓకే ఓకే ఓకే, థ్యాంక్ యూ.
You have to do gonio 80 gonio per every patient, Shilpa and Sonika.
Sir.
Okay, with this we'll conclude the thing.
Sir, 1 minute, sir. This combination, sir, this chart showing combinations, this is correct now, sir, for because in individual chart they are showing all the available concentration.
Yes.
Here this combination chart, they are showing the correct 0.03 bimatoprost.
Not correct. They will have something like some US companies, they might be given like this. So you'll have a different combinations also in this also.
Okay.
So bimatoprost is having 0.03 and 0.01. Both the things are there in with Lumigan. So you should not write just Lumigan.
Okay, sir.
Write the concentration also. 0.01 and 0.03.
Okay, sir.
You have to mention that.
Okay, Lumigan 0.03 bimatoprost is also there, different combination like concentration. Lumigan.
Yeah. Both Lumigan is there at both the concentrations.
Okay.
If you just write Lumigan, they don't know.
Okay, sir. Okay, sir.
Okay. You have to mention 0.01 or 0.03.
Okay, sir.
Both the things are available with Lumigan. So when you come to the fixed drug the company may develop the concentration which they want to do. So brimonidine, so did you heard about Alphagan?
Yes, sir.
So Alphagan has 3 combinations: Alphagan P and Alphagan Z. So Alphagan is 0.2%, Alphagan P is 0.15% with BAK, and Alphagan Z is purite preservative. Purite preservative with 0.15. So that difference is there, commercially available also. But Timolol we don't have in India. Only 0.25, 0.5 which is available.
0.5. Okay, sir. Thank you, sir.
Thank you, sir.
You conclude the meeting, right?
Sir.
Madam, conclude chedam. Okay.
Sir, thank you, sir. Thank you, sir. Thank you, ma'am.